Sure, the peer pressure of getting up and speaking without the lectern. First, I agree with Dr. Fessler for this morning, Michaela and Tyler and Jerry and Hannah. Wow, thank you. And Jim does such a great job of synthesizing a very complicated topic and making it look simple. So thank you. Jim and Dr. Fessler really talked about some of the acute issues. I'm going to talk a little bit about the rehabilitation aspects. So the subacute time period, which is about 2 weeks to 3 months after a spinal cord injury, is oftentimes spent in rehabilitation. This is a great time to see some natural neurologic recovery as well as functional recovery. But it's also a great time to be able to incorporate research as well. But there are some challenges. There are challenges in the acute period, as we've heard, but there are challenges that are in the rehabilitation period as well, and I break them into these 5 different categories. But I think what's important, what I'm going to try to do today, is not only give you the problems, because you probably already know the problems, but try to find ways to mitigate them so that we can be much more successful in recruiting patients, keeping them into the clinical trials that we have. So I'm going to try not to repeat some of the things that we already heard about. We heard that to some degree there's an unpredictable nature. It's seasonal in many parts of the country, so being able to predict when patients will come in is not easy. There are varied times from patients, from the time that they have their injury to the time that they come into rehabilitation. So in the acute center, everybody's there within a couple of hours. But sometimes into the rehabilitation hospital, they can come 3 days or 3 weeks, and maybe even longer. And we heard about the heterogeneity of people with spinal cord injury. We have those that have neurologically complete injuries, Asia Impairment Scale A, to those that have incompletes, whether it be Asia Impairment Scale B, C, or D. And these really play a role in how to recruit people into our studies. But I think that it is also important to note that there's greater stability from a neurologic standpoint of recruiting patients at least, let's say, a few days to a few weeks after injury. Certainly those of you who are involved in studies that take place within the first 24, 48 hours know the complexity of how many people come in and in the first few hours and the baseline exam shows that they're a neurologically complete injury, and then just naturally they will become incomplete. And it had nothing even to do with the intervention, but this also throws off your placebo group. Your examinations and your classifications are much more stable over the course of the next few days and weeks post-injury. We heard a little bit about the changing demographics, so I'm not going to repeat it. So we know that there are older age that are being injured at this point, and some studies have exclusion criteria based upon the age. We also heard that falls is closely becoming the #1 cause of injury. It's certainly the #1 cause of injury in people over the age of 45. So this really impacts the amount of people that we have. But it's also important that there was a recent paper that showed that about 32% of new injuries are classified as central cord syndrome. Now, even though there's not a 100% clear definition of central cord syndrome, there are some studies that exclude patients with central cord syndrome being part of them. So that's excluding a lot of people that may have injuries. We also have a decrease in complete injuries, and there are many reasons, good reasons, why people with complete injuries were recruited into trials. Certainly it's a more homogeneous group. You don't have that worry about a ceiling effect in terms of recovery. And boy, if you can show some good effect in a person who's supposed to have a poor recovery, that really will be amazing for your potential for further study. And also the issue of do no harm. If you have a interventional trial, you may not want to do it in a person who already has a very great prospect of recovery. So all of this leads to a potential decrease in recruitment. What we're also seeing is some other trends that really do impact the ability to do research within that time frame. Number one, not everybody's going to the larger spinal cord injury rehabilitation centers. Now, one of the great advantages of going to one of these centers is not only from the expertise in the clinical care, but these centers also are the ones that have research infrastructure, right? So that's really important to be able to do that. many people, if they have incomplete injuries, may not go to those centers because they may not need as much. They may not want to travel to one of those centers, so they'll go to more of a local center that's not engaged in research. Also, depending upon the age, if they may not be able to tolerate the 3 hours of therapy, so they may first go to a skilled nursing facility, or maybe depending upon their coverage, will push them more to the skilled nursing facility. Or in some parts of the country, if they have a high-level injury and they're on a ventilator, they may first be sent to a long-term acute care hospital and then later go to the rehabilitation facility. But by that time, they may have already passed the deadline of recruiting them into the trial. Now, one of the other effects of this is that if you are a major spinal cord center and you have the research infrastructure, well, you probably also have a number of different studies that you're performing that may have similar type of inclusion criteria. And that causes a little bit of a problem on behalf of the patient, because if you have different research coordinators who are all really looking to get people enrolled in their particular trials, this causes a degree of competition and bombardment, even within the patients themselves. And this is really hard, because this becomes now the patients feel almost like, what are they going to do? It's a decision fatigue somewhat of being posed different trials and trying to figure out what to do amongst everything else that they're going through at that point in time. It seems easy, right? Some people, I speak to my colleagues in the acute hospital, they say, boy, it's so much easier for you in the rehab. We have only a few hours. We have to get things done within 12 hours or 24 hours or 48 hours. You have so much more time. Or you know when patients are coming in. I say, that's true. And the grass is always greener, I guess. But, you know, it's hard. The person comes into the rehab hospital, they've got to now meet with the entire rehab team. They got the therapist. There's a lot of people in a comprehensive rehabilitation team. And they're going through evaluations. They're going through testing. I think it's also important to recognize that, and again, I'm not saying one's better than the other, but in the acute hospital, the patient may be going for surgery, they may be going for tests, but the rest of the time they're usually in their room. It's called sort of being the passive recipient, is what the patient may be. Whereas in the rehab hospital, they're the active participant in what's going on. They're supposed to be out of their room. They're supposed to be engaged with things. So it's not so easy. Sometimes I get a call saying, where is the patient? You promised me they'd be in their room at 4 o'clock. We heard a lot about informed consent, so I'm not going to repeat all the things that you heard before. But there's a lot of discussions that need to go on to educate people about what they're really getting involved with. And it is a relationship. You need to develop a relationship. And I absolutely agree, Jerry. I tried to tell very hard, look at the person. It's not a form. It's not a subject enrollment. They think, okay, well, you're subject SK number 22. But it's also different because families need to be involved. And I'm not saying, again, one's better than the other, but by the time the person's come to rehab, the family has gone back to some degree to their life. They have to go back to work. And now you have to start dealing with, well, when is the family available? What do you mean they're only available at night? We only work from 9 to 5, or whatever the case may be. So these are important issues. We also have to take in mind that there are a lot of logistical issues in the rehabilitation hospital. There's a schedule, and I don't want to say that it's rigid, but there's a schedule that needs to be kept. In rehabilitation, you need to justify the person staying there, there's 3 hours of therapy a day. Including now, on top of that, you have psychology and vocational counseling and peer counseling, dealing with the case manager, medical follow-ups. Oh wait, they have to eat too, right? And they need some downtime. Oh, and they also want to spend time with their family and friends. Well, where are you going to fit in research? This is not so easy because you have to fit in. So where are you going to fit in? And if you have a research project that's multiple hours per day, wow. And resource availability. So you need, if you're a research lab, you need to have staff that are available whenever people are ready. You have to maybe before hours or after hours. And then are you going to do the intervention in the patient's room? in the therapy gym, or are you going to take them into your lab because you have specialty equipment, and now you're taking them off the floor for even a longer time period? How will this impact the person when they're just trying to accommodate to their new injury and learn about their injury? Patients may be a little bit more stable in the rehab hospital than they were in the acute facility, but there's a lot that goes on. For any of you that have worked in a rehab hospital know, there's a lot that takes place during this time period, right? At first, hypotension. And then a few weeks later, they go into developing autonomic dysreflexia. They have bowel and bladder issues that need to be dealt with. Urinary tract infections, we heard about that. Developing pressure injuries. Heterotopic ossification, new onset of spasticity, right? Pain starts to develop. All of these issues, if you start the projects, these are now adverse events. They may not be related to the study itself, but they still need to be documented. Now, I do mention also emotional, psychological challenges. Individuals who have had a spinal cord injury are going through a lot. Not just they're going through therapy, but emotionally. They're learning about their injury, how this is going to impact their life. And sometimes they say, well, I just don't feel like going to therapy today, or certainly I don't feel like going to the research intervention today. So you need to keep that in mind. And then this is to remind me that about 11% of people who are in a rehabilitation hospital for spinal cord injury end up getting transferred back to the acute hospital for one reason or another. So that needs to be taken into account as well. We talked a little bit about this yesterday, about outcome measures, right? The most common outcome measure that we use in a rehabilitation hospital, because we're mandated to, is the CARE tool. But I don't see any validated work on the use of the CARE tool. We use some of these other outcome measures. So that means that we're now adding measures onto every single individual. And that takes time from the research perspective, but more importantly, on the individual. Now they have to, they went through the evaluations of their rehab team, and now they have to go through even more evaluations. And they say, wait a second, why can't you just use the ones that they did before? Short length of stay. A lot of times that we like to use admission to discharge as two time frames within a research project. But we have to remember that lengths of stay are shortening in rehabilitation, and that the difference between admission and discharge may not be as great as we had hoped. But an even more important aspect is that when the person is working directly with the therapist before they go home, the therapist is really pushing them, okay, try to do it, try to do it. And it really doesn't matter how much time it takes to do it. When the person gets home, then all of a sudden, you do a phone call and say, okay, well, are you dressing yourself? And the patient says, no. Well, you were dressing yourself last week when you were in the rehab hospital, because you're adjusting to the situation. And it's important to keep in mind what markers you're using to make sure that the person isn't, let's say, worsening just because of the outcome measure you used. Retention and follow-up. We talked about this yesterday, about how important it is. Not everyone goes home after a spinal cord injury. And this, if a person goes to a skilled nursing facility, maybe because the home isn't ready, or for insurance reasons, or the family quite isn't ready yet, it's not as easy to bring the person back for different types of procedures, whether it's intervention or outcome measures. Or sometimes the person goes home and the home isn't ready either. They can't get out that easily. Or there's logistical issues like transportation or scheduling. They have to still go to therapy. We heard that before. They're going to therapy. Or the time frames that work for the research group is not the time that works for the family based upon everything else that's going on in their lives. And again, the adjustment factors. And this is really important, because when the person goes home and they're now adjusting with their family, the community, the other aspects that's going on, and they say, what am I getting out of this? Is this really working for me? And we have to make sure that it is. So let's not just talk about I spent half the time, or I guess I spent more than half the time, so I got to move. Okay, recommendations. So we saw about this funnel effect. Kim Anderson wrote a great article about the importance of what we can do, potential functional improvement, and I really recommend reading this article. It's really very helpful. We also talked yesterday about getting everyone on board, making sure that the patients are involved in designing. But let's go through some real specific things that I think could be helpful. Number one, we need to implement stratified randomization Jim did a great job talking about this and include persons with incomplete injuries, but the right ones. I think this is really important in terms of designing a trial that's not just the classic randomized, placebo-controlled trial, one-to-one. We need to look at newer ways of doing this and finding ways to include persons with incomplete injuries. I also think we need to develop relationships, those hospitals that are dealing with these types of studies, develop relationships with skilled nursing facilities to be able to incorporate the research infrastructure we may have to be able to recruit additional patients who may meet criteria. Education of patients, this is critical. I remember of the saying, I mentioned, I think, to Marco, that Cy Sims, the educated consumer is our best customer. You really, educating individuals about their spinal cord injury is the right thing to do, but it also will help you in terms of research. What we do is, by us, is that I every 6 months, have a new handout on all the different research projects that we're doing. We do not give it to patients because there's no coercion, but it's available. The nurse manager, therapy manager, the spinal cord coordinator has this available. If patients ask, we give it to them. It's written in very lay language, and then who to contact for more information. So I think it's really important that they're aware of it. And every 6 weeks, I do an open forum for inpatients. It's hybrid so that families can join as well, where I talk about research. I give literally only 5 to 10 minutes about research in spinal cord injury around the world. And the rest of the time is questions from families. And it never ends at an hour. It is just go on. Families are so educated now, there's so much on the internet, so educating is important. And then we need to simplify the informed consent process, but making sure that it's complete. Obtaining consent is important. The point I'll make about here is that there's no doubt that involving the clinical team members is helpful in obtaining people for studies. But there's a real ethical issue with doing this. Right? There are studies that show that individuals with spinal cord injury almost feel pressure to say yes when their clinician approaches them. And so we really need to think about that it should be a neutral party. Kathy Craven wrote a great article on this, and I recommend that, so that to make sure that people do not feel pressured that it will get in the way of their treatment if they were to say no. Logistical issues, we did talk about this yesterday, making sure everybody's involved, integrate research into the activities. My experience is it failed. When a person was enrolled in a trial and we said, okay, let's add it on to your schedule, it didn't work. It just meant that they had to do it at 6 a.m., which no one wants to do, or do it at 5 p.m. when people are tired. So what we do now is that once a person enrolls into the trial, it is a joint method of the scheduler, we have a schedule on every floor, works with the research team to see when the research can work, when the clinical activities can work, balancing clinical care with research when the patient wants it. That's the best way to do it. If it's just an afterthought, that's what's going to happen. It's going to be an afterthought. Use flexible and scalable research infrastructure. Well, we can talk more about that. I see I have 2 minutes left. The medical aspects is really important. We talked about how much goes on, and there could be a lot of changes. The words I would say about this is, if you see something, say something. And what I mean by that is that we insist that there's a handoff. Whenever a person is going for a research project, the primary nurse or the primary therapist who's ever getting the handoff, giving the handoff to the research person, has to say, this is how the person's been during the day, to make sure that there's nothing, that the patient isn't feeling up to it. And then when the person is brought back to the floor, there has to be that handoff of, this is what happened, or we think that something is going on, please keep a close eye on it. This is really critically important. I think we have to be very careful with our outcome measures. Sometimes I hear, and you sit in meetings and you say, oh yeah, let's add this one. Oh yeah, let's add that one. And then you say, wait a second, there are 14 hours of outcome measures per day. I mean, how is anyone going to sit through that? You really have to understand what you're asking the person to go through, not just what you're asking each individual research person to be able to do. and align clinically relevant outcomes with real-life activities. And I do believe that subjective opinions are very important, and finding the right questionnaires to do that. Communication is critical. Communicating across the board, clinicians to researchers, researchers and clinicians to patients, to their families. You need to keep them engaged. And when they're ready to go home, make sure everybody knows when the follow-up is going to be. Provide incentives, transportation, making sure that it works with their therapy schedule or with medical follow-up schedule to make it conducive for coming in. Telemedicine, home visits, these are all ways to really mitigate it. Some people say, well, it's very expensive to do that. To me, there's nothing more expensive than recruiting a patient, enrolling them in the trial, doing halfway through, and then having them drop out. That's a major expense. And last is, make it welcoming, right? Have coffee. If a family is bringing the person, make sure that there's coffee. Make sure that people feel welcome. It's not just the individual, it's the people that are bringing them on a day-to-day basis so that they really feel engaged and part of the team as much as possible. So I hope that this is somewhat helpful to you. There are challenges of doing it in the rehabilitation stage, but I think that there are some tremendous ways that we can do it. You can balance it with clinical and research and really allow this to be successful. Thank you very much.